Hey everybody, my name is Ethan Young. I got asked to help with your training this month, and I wanted to start by introducing myself to all of you since unfortunately because of COVID I have not been able to make the FaceTime appearances that I would have otherwise wanted to. But I have been brought on as your new medical director. I am currently working clinical shifts between St. Joe's up in Chippewa and Sacred Heart here in Eau Claire. I just wanted to give a little bit about my background at the same time. I'm originally from South Dakota, where I did work as a paramedic for about 5 years on two different county ambulance services, running both 911 calls and interfacility transports. I did my undergrad studying also in South Dakota at the University of South Dakota, where I studied business. Ended up being lucky enough to get into medical school, and I did that in Chicago. And after med school, I went on to do my residency in emergency medicine in Monroe, Michigan, and Toledo, Ohio. And then this last year that I wrapped up at the end of June, I was spending a year in Houston, Texas, working as the assistant medical director of the Houston Fire Department, where I was doing an actual subspecialty training in EMS to learn how to be the best medical director I could be. I always knew that I wanted to be involved in EMS ever since the pre-hospital days that I worked many years ago. But I'm very happy to be here with you guys and present this month's topic to you, and I hope to be able to meet all of you in person at some point coming up here when this COVID thing cools off a little bit. The topic that I got asked to talk about is stroke, and specifically as it pertains to you guys as the first responders out there. There's a lot of stuff to know, so we'll kind of dig in, and some of this will be a little bit of the perspective into how we look at it on the ER side of things, but hopefully the meat of it will be, directly useful to you in terms of, the next stroke call that you guys respond to, what we need to do, what we need to know, and that kind of thing. So in the broadest sense, a stroke is a vascular injury that reduces the brain's blood flow, and this has to cause neurologic problems for it to be a stroke, and these neurologic problems can be really anything. We'll talk about them a little bit later in this presentation, but this is the classic weakness, numbness, tingling, even things like visual problems or balance issues can all fall under this category. It can absolutely all be signs and symptoms of a stroke. Strokes are broad and divided into two different categories. Ischemic strokes make up almost 90% of the strokes that we're going to come across, and these are further broken down into thrombotic and embolic. And admittedly, for you guys as the first responders out there, there's not any difference that you would know about by being able to physically look at somebody to tell whether or not it's an ischemic stroke or a hemorrhagic stroke. But this is more in the academic sense. It's also important to understand what's going on in the background with these folks. So like I said, almost 9 out of 10 of the strokes that we come across are ischemic. Most of those are going to be thrombotic, which the difference between thrombotic and embolic strokes is a thrombus is a clot that develops right in that spot. So these are strokes that develop because a clot clogged off the artery in the brain. And embolic, that is going to be the rarer circumstance where a clot shoots off from somewhere else in the body and lodges in the brain. And these can come from heart valve problems or holes in the heart and things like that. That's the much less common cause of ischemic strokes. Then the smaller percentage, the 13% are the hemorrhagic strokes. These are the intracerebral bleeds, which this is a representative CAT scan of something like that. This is an area of blood here within the brain itself. And then if you've also heard the term subarachnoid, that's a different kind of bleed. There's not a representative CAT scan. Again, not a big reason for you guys to know the distinction out there other than, we should really know what we're dealing with and having a head bleed has different implications when it comes to checking our vital signs and what we would hope those to look like when we're checking over our patient out in the field. TIA really is not a separate kind of stroke. What it is any of these neurologic deficits that we came across as we identified them before, but the thing that separates a TIA or transient ischemic attack is the time frame. And most people, used to think that these are symptoms that get better within minutes or even an hour. The technical definition of a TIA is you have 24 hours for these things to get better. And if you have a complete resolution of the weakness or the facial droop or whatever symptom you were dealing with within 24 hours, that technically falls into the category of a transient ischemic attack. Risk factors are all the classic risk factors that you would think about in terms of somebody who's sick and is prone to get any number of health problems. These are things like your high blood pressure, your cholesterol, clotting issues. Then you've got stuff like the growths on the heart valves, low blood pressure for any number of reasons, and this could even be something like a completely separate issue, like a septic patient that's dealing with low blood pressure. If you have your patient there that's used to living at a blood pressure of 200 over 100, and now you have a septic patient and their blood pressure is now 80 or 90, they're completely unprepared in the way their body regulates things for that blood pressure, and just the lowering of the blood pressure can cause stroke-like symptoms there. And of course, things like drugs, cocaine specifically, things that cause spasms of the blood vessels can cause bleeding, or it can just block off blood flow in the same way that those blood clots would that we were talking about previously. Moving on from more of the background and the less exciting stuff that all these lectures usually come with is the more pertinent things, the hands-on things that you guys are going to have to be prepared to deal with in terms of being out in the field and responding to these people with stroke-like symptoms. Back, I remember my days as a paramedic, it was tough because these would often get dispatched as things that weren't actually strokes. It could be the weakness or fatigue, and not until you got there would you really, estimate that you're dealing with a stroke victim or things like that. So being prepared when you enter the scene for that at all times is a pretty important thing. But at the first responder level, we have to always be prepared to handle the ABCs. That's the most important thing. Specifically, in my opinion, when it comes to strokes, being prepared to manage the airway. That's why I threw the little cartoon of the bag valve mask up here, because if your neurologic issues from your stroke are severe enough, you can absolutely lose the ability to protect your own airway from things like your own tongue or your saliva, and being able to breathe on your own if you have an altered level of responsiveness or anything like that could absolutely be something that we don't have. So being prepared to put in something like an oral airway and ventilate them with the bag valve mask would be very important. And then one of the other super important things at the beginning is checking a glucose level. And this is included a little bit later in this lecture in terms of just reminding you why it's important. But low glucose can mimic a lot of things, and stroke is one of them. So if you have somebody, especially with the history of diabetes, in terms of those risk factors, making sure you're not dealing with somebody that has a sugar of 20 or a sugar for 1,000 of that matter, because they can both cause wacky symptoms, and you would think less likely that you're dealing with a true stroke if you have sugar that's way out of whack, and only if those symptoms are there after the sugar starts getting fixed would you really be able to dive down and know if you're dealing with a stroke or not. So physical exam, this is what is going to tell us that we're dealing with a stroke. This is everything from strength to sensation to vision to even things like balance and coordination. And we'll talk about a little bit later why that part of it makes the idea of a stroke not so simple, not so straightforward, because that is a lot of things. The balance and coordination can be things like vertigo or any number of other issues, but it can also be a sign that one of your blood vessels that goes to the back of your brain, your cerebellum, got blocked off, in the same way this big chunk of your brain could cause, arm and leg weakness. If that cerebellum gets its blood cut off, you can lose your balance, you can lose your vision, and things like that. So it's tough to really tell. And one of the best ways and most well-studied things out in the EMS world is the Cincinnati Pre-Hospital Stroke Scale. And this is pretty simple. It looks at mainly three different things: your facial droop, which is sometimes not so clear. It can be a pretty subtle finding, but usually what I've found successful, at least in the ER world, if these people are accompanied by somebody who actually knows them, we can have them, look at their face. They look at their face every day and say, does this look normal or does this not look normal? And they get a score. If it is looking like this over here, if it's got some flattening of the nasolabial folds, we call that, or, the facial droop, the corner of the mouth. Over here, we're arm drift. What you want them to do is close their eyes. That's an important point when you're testing this thing. Have them close their eyes, have them hold their arms out in front of them, and see if one of the arms drifts down. And the reason it's important for them to close their eyes while they're having this physical exam maneuver performed on them is because if they're able to look, they're naturally not going to want their arm to drift, and they can compensate. If they have their arms out in front of them and they see one of the arms start to drift, they can start raising up their shoulder. And I know that probably didn't come across great on the webcam here, but basically they're going to compensate in any way they can. And if you don't completely notice, if they're pretty slick about how they're doing it, you might miss a potential indicator of a stroke with this arm drift. And then abnormal speech is the last part of the Cincinnati Stroke Scale. On this little cartoon, they recommend having the patient say, you can't teach an old dog new tricks, because that is most mouth and word positions that would be affected by having a stroke or a tongue weakness or a mouth weakness. If they're able to say this, it means two things. One, they're able to understand the instructions that you've given them, which counts for a lot. They're following your commands, they're able to repeat things. Their memory's okay, but abnormal would be anything from them slurring the correct words to them completely messing up what you told them to say, and that counts for something in and of itself. If they're not even able to repeat a sentence that you just told them 1 second ago, that could indicate a lot of things, not just stroke, but a level of altered mental status or inability to follow commands, and that's useful information to pass on to the transport unit as well. The last thing to remember down here, they included, if even one of these things is present, they're saying the probability of stroke is 72%, so that's pretty high. I would agree with that. Other than the facial droop, there's a super common mimic that we will talk about here towards the end of this presentation, called Bell's palsy, that can cause a facial droop. And I don't expect our first responders to particularly be able to notice the difference or tell the difference, but facial droop does not always mean a stroke, especially if it's a young, otherwise healthy person that just has a total facial paralysis. So I said at the beginning I would kind of give a little bit of insight into what we do on the hospital side, because I always found that a little bit valuable. Well, back when I was on your side of things, knowing, when I get the patient packaged up and bring them in, this is what's happening on the other side. Because we have more time with the patient, we're able to use a little bit more labor-intensive stroke scale. And that's the NIH stroke scale, or the National Institute of Health stroke scale. This is probably 20 criteria, something like that, and you can get multiple points in each criteria for things like weakness in the arms, weakness in the legs, visual field issues if you're not able to track, and not being able to repeat words and things like that. So this is a way that we can stratify things when they come into the emergency department. And some people can live at some deficit if they've had a previous stroke. not everybody previously had a stroke score of 0, so knowing what deficits they were dealing with before they even came in is important. But this gives us a good idea of what we need to do and how aggressive in terms of treatment. In the ER, the big question that we're always asking ourselves is, do we need to give a medicine that can dissolve clots? And part of that decision is severity of symptoms, and we try to be objective about saying how severe things are. And this makes it a little easy when we throw it into our calculator after our physical exam. 0 does not mean there's not a stroke. That just means no stroke symptoms as it's defined by this stroke scale, but then, minor, moderate to severe. So really, if you've got stroke symptoms anywhere in these middle 2 to middle 3 here, the consideration, if you meet all the other criteria to give that clot dissolving medicine, would be given. If there's not enough symptoms, or you're completely debilitated, the hesitation would be there to give any sort of clot busting medicine. So moving back to important things that you guys need to ask when you run on somebody you're thinking might be a stroke and you got called out and you've done your pre-hospital stroke assessment and you've decided that there's some deficits. It's very important to be able to relay to the transport units and that they relay accurately to us in the ER what the last known well is. And what this means is the last time that the patient was normal. And if this was a patient that was around friends or family, sometimes that's an easy question to answer. More often than not, we don't know because they either weren't by them, they weren't around people, they were by themselves, or they didn't immediately notice it, or they woke up this way. And that's called a wake-up stroke. And we're changing our opinion about how we treat those a little bit, but if there's an absolute last known well, drilling down as exact as we can be, even saying something like 923 or something like that is super helpful. But if we don't know, we don't know. We can estimate or say, this last known well was last night when they went to bed at 9 p.m. It's tough to tell. But if we are able to get an accurate estimate of their last known well, that's another piece of the formula that goes back into that decision for the clot busting medicine that I was talking about on the previous slide. We absolutely, the way medicine is practiced currently, need to have a last known well less than between 3 and 4.5 hours to be able to give that medicine. And it's debated on how effective that medicine is anyways, but if we're outside that window, you'll hear it maybe called the TPA window. That potentially, super aggressive, but maybe will help them drug is off the table. And, that is something we have to offer them when sometimes there's not a lot in terms of these strokes. If the damage has already been done, there's not a lot we can do to undo it. So this is a critical piece of the formula, and you would be expected to be able to relay this to your transport units and to the docs in the ER and the staff in the ER. So moving on to the next slide here. The thing that you're hopefully doing on every patient that you come across, whatever mnemonic that you want to use, is getting an EMS level medical history, which this is what I learned back when I was in EMT basic school and paramedic school, the sample history. It's easy to remember and it hits all the major stuff that I think matters, especially in the setting of strokes. There's not a lot on there that we wouldn't get if we're just going down this sample mnemonic. Specifically, the things to remember in terms of important information: of course, your past medical history. We already talked about those risk factors, so your index of suspicion for something like a true stroke is going to go up if they've got all the classic medical problems, your blood pressure, your diabetes, your cholesterol, or other cardiac diseases and things like that. In terms of medications, being on a true blood thinner is something that's very important to know about. And true blood thinners, the distinction between them and things like aspirin is not always explained super well. But if you hear a medicine like aspirin or Plavix. Clopidogrel is the generic of Plavix. Those are not considered blood thinners in the way that we classify them in the ER and things like that. What those are antiplatelet medicines. They stop the platelets from sticking together, but it doesn't actually interfere with the blood clotting as it would otherwise happen. It's just an antiplatelet medicine. And that's why you can sometimes see somebody on an aspirin and a Coumadin at the same time. True blood thinners are things like that warfarin or Coumadin. You know, the thing they need to go get their level checked every once in a while to make sure they're not too thin or too thick. Something like a Xarelto, something like an Eliquis, those are all the most popular medicines right now in terms of true blood thinners. So if you're able to recognize those three, I think you're, looking pretty good in terms of being able to pass along this information. The reason that it matters is going back again to the ER side of it when this patient finally gets delivered to me in the hospital. If this patient is on a blood thinner, if it's on an Eliquis or something like that, or a Coumadin and their level is high enough to be therapeutic, that automatically disqualifies them from being eligible for the clot busting medicine as well. So these of course are questions that we would ask, but if this is a patient that is pretty critical and you have a family member that you're able to get this information from while you're on scene, and they can't ride in because it's COVID, and we can't get the history otherwise because this patient's unconscious once they get to us in the ER, to know their medication list is super important. And if you guys are able to suss out the super important things like blood thinners and history and things like that, that would be extremely useful so that we don't end up doing something dangerous in the emergency department by giving a clot busting medicine to somebody who's already thinned out on a blood thinner. The thing that hopefully would be obvious but sometimes is not so obvious is this last little point that I put here on the slide, the trauma. And specifically, this increases our index of suspicion for that less common type of stroke, that hemorrhagic stroke. If there's trauma, the old person that fell down the stairs, or the MVA, or whatever it is, it can be any number of things. We have to consider more strongly that this could be, a hemorrhagic stroke, not one of these ischemic blood clot kind of strokes. And, that's the reason that we have all the metrics in the ER. If you've actually seen one of these people get brought in, they get whisked off to the CAT scan very quickly. And the reason isn't that we're looking for a stroke on that CAT scan, because if the stroke is fresh enough, we have no chance of being able to see that stroke on this initial CAT scan because we're not using any contrast or anything. But the thing that we're looking for is a head bleed, because again, that's something we're thinking about. Time is brain essentially, and do we need to go ahead with this clot busting medicine? And if there's a head bleed, of course we're not going to want to thin their blood out or bust up clots or anything like that. That would be murder essentially. So if we know that there's trauma, that really would steer us down the pathway of being a little bit more conservative when it came to that kind of medicine. Of course, taking a good set of vital signs is also super important, and it is expected from you guys. Blood pressure, I would argue, is one of the more important things after you're able to, check your ABCs and make sure that there's no assistance required with those. Blood pressure gives us a good idea of what's going on, because we also have an upper limit of blood pressure that we're able to give that clot busting medicine, the TPA. If they're over 185, it's a medicine that's too dangerous to give, so we would have to drop their blood pressure down first before doing it. There are certain patterns that are probably not as useful to you guys to know at the first responder level, but if you've got super high blood pressure, super low heart rate, in the 30s or 40s, and they're breathing all wonky and things like that, that is something that can be a sign of increased pressure within the head, and that would make us think something like a head bleed and those kind of things. So in the same way we'd worry about, a sky-high blood pressure in somebody with, arm and leg paralysis, having a super low blood pressure is the same thing. why would it be super low, especially if this is someone that was dealing with super high blood pressures beforehand? And then, COVID is directly linked to vascular disease and things like that, and vascular problems are a risk factor for strokes. So, having your suspicion in terms of checking temperature, and if you're able to ask a history of recent type viral illnesses, cough, congestion, those kind of things, to give us an idea. Specifically COVID would not stop us from giving the TPA medicine, but it's always good to know. And I think at this point, if you're watching this in November of 2020, we are considering that everybody probably could and does have COVID that comes into the emergency department. So we're being careful about it anyways. But it's an important piece if we're able to relay, fever, no fever, heart rate, and blood pressure. I think are the most important things as it pertains to stroke. I mean, having the complete set is ideal, really, but those are the most important things when it comes to stroke. There are some protocols for the paramedics that if they are strongly suspecting a stroke, they are able to give some IV medication to drop the blood pressure, with the only goal being getting it into the range where we would be able to give that TPA medicine once they get to the ER. Dropping a blood pressure of 240 over 120 down to 120 over 80 would never do anybody any good, for that reason that we already talked about at the beginning of this lecture. If there's somebody that is used to living at that super high blood pressure, their body adapts to it, and when they don't have that high blood pressure, we create areas in the brain called watershed zones that, because they were used to this high blood pressure and now we took it away, they can't get blood to the ends of those watershed zones, and we can actually stroke people out. So that's why in the ER, this is a little bit of a tangent, but if somebody comes in that's otherwise feeling well with a blood pressure of 200 over 100, we're not super aggressive at taking them down to a 120 over 80, because you can cause all sorts of problems, including stroking somebody out right in front of your eyes by doing the wrong thing with the wrong medicines. And that's just more, kind of thinking about the pathophysiology for you guys. I understand you're not going to be dropping down blood pressures and things like that, but just to know what's happening on the other side of things, I think makes you guys better first responders as well. So moving on, this is kind of a culmination of everything that we've been talking about in these previous slides. Before we get to the end of the talk here, the most important things for you as the first responder units, the people that are making first contact with these potential stroke patients. Number one, I'm going to sound like the National Registry test, but the most important thing, of course, is ABCs. If you're a whiz and you diagnosed a stroke, but they're not able to breathe for themselves and they have complications from not being able to breathe because you forgot the basics, we're not really doing them any favors. So getting in there, first and foremost, making sure their ABCs are secured, making sure specifically that we don't need to insert an airway adjunct and do some bag valve mask ventilations for them. Glucose is something that cannot be forgotten, because, like I said, both super low and super high blood sugars can cause strange neurological symptoms, and that can include one-sided neurologic deficits. So if you have somebody acting weird, acting weak, this is absolutely part of the assessment that we need to remember and know about. Vital signs, we just talked about that on the previous slide. Look specifically for the blood pressure, and all that information is important and great to be relayed to us in the ER. Then the last known well, it's not going to help you guys in the field care for this patient any better, but it really makes an enormous difference when that gets relayed to us in the emergency department, especially if they're within that window for that clot busting medication. And again, that is no more than 4.5 hours. So anything that we have an accurate guess that's greater than 4.5 hours is not very likely to get any sort of clot busting medicine. So before we go to mimics, I'm going to flip it back to this slide. So I kind of left that that last little bit, saying that 4.5 hours is the limit for getting this clot busting medicine. So, what do we do when we have a patient that woke up like this, woke up completely paralyzed on one side of their body. Uh, they woke up, and then, we can't say that it for sure was in this 4.5 hour window. Do we have anything to offer? The answer is definitely yes, especially for major strokes, what we call an LVO, or large vessel occlusion. That's basically the main branch of the artery in the brain. If that whole branch has a big blood clot in it, that's the perfect candidate for what we call a thrombectomy. And this is a procedure that has a time window of being effective of about 24 hours. So if we catch anybody within that first day, especially with major symptoms, we absolutely have things that we can still do for them. So even if they are outside that window, if they have major symptoms, we can do special CAT scans in the emergency department to light up those blood vessels and see if there's anything blocking them off. And here in Eau Claire, we have the specialists that are able to get in there under X-ray guidance and open up those clots and suck them out or break them up. And there's a lot of great literature supporting that does great things for the recovery of the patient, sometimes even a lot better than that clot dissolving medicine. So for major strokes, we have that in our back pocket too, and we have some great specialists from interventional radiology and neurology here at the hospital. Sacred Heart is what I'm most familiar with, but they're all over the place and they're able to do some incredible things. So 24 hours is really the upper limit for any sort of intervention. 4.5 hours is the limit for the IV clot busting medicine. So jump into some more academic things after hitting on what's most important for you. We've got mimics. And what this is a group of things that can look like a stroke, but is really not attributed to a blockage of blood or an impairment of blood flow within the brain. And the first thing is a seizure, and you wouldn't think that specifically a seizure. Of course, we can see somebody having convulsions on the ground. That's not a stroke. But there's a rare variant called Todd's paralysis, and this is in the postictal part of the seizure, or the part where they're done having the convulsions, but they're still out of it. They're tired. They're not communicating with you. In this Todd's paralysis, you can have weakness on one side of the body or the other. You can have what we call focal deficits, which is something on one side versus the other. But it's completely unrelated to blood flow to the brain type issues. It's related to your brain resetting after this seizure, because everything is, in the end, it's controlled by brain waves, and seizures are abnormal brain waves. So if you have issues coming from one side of the brain, you can see one-sided symptoms related to seizures. So going back to your history, what would be super important to know is, was there any sort of seizure activity? Is there a history of seizures? If there was any sort of seizure activity, our willingness to give that medication in the ER is going to go way, way down, and that's super important information to get passed along the chain to get to us in the ER. We've already hit on this 2 or 3 times, but the blood sugar issue, it cannot be forgotten. Getting this blood sugar, high and low blood sugars, can cause these things, but we've already spoken about that. And the third thing that I included here under mimics is Bell's palsy. I alluded to it right at the beginning in terms of the facial droop that we're looking at in the Cincinnati Pre-Hospital Stroke Scale. What this is not a stroke in the sense that there's a part of the brain that's causing weakness of the face, but this is actually an inflammation or infection of the facial nerve. You have a facial nerve that controls everything from forehead all the way down to the corner of the mouth and everything like that. It can get inflamed for a number of reasons. Living in Wisconsin, we have to think about Lyme's disease. That's a big reason here, but otherwise it can be viral. Viruses in the herpes family can cause Bell's palsy, and sometimes we have no idea why it happened. But these are the patients that, if they're young, otherwise don't have any risk factors, they feel fine, otherwise no headaches, their speech might be a little unclear from not being able to close their mouth all the way, but their whole face is just weak. There's no wrinkles in the forehead. This is a diagnosis that we need to consider. And it's not really your job to determine whether or not this is a Bell's palsy or a stroke. If they're concerned enough that they've contacted EMS, I think they should at least be evaluated by a doctor. But if this is pretty clear cut, based on the things that we look at for physical exam, these patients often don't get even a CT scan in the emergency department. If we're confident based on everything, what we'll do is give a course of steroids and some antivirals usually. Or if it's Lyme's, give the antibiotic for that. So moving on from these mimics listed on this slide, I wanted to include this, and again, I fully understand that you guys don't have CAT scanners and things like this, but I'm bringing this up for a very specific reason. What this is a cartoon of the blood supply in the neck and the brain. What I wanted to look at down here are the vertebral arteries and the spinal arteries, if you're able to see what my cursor is hovering over right now. These are arteries that run up in the neck to that cerebellum portion of the brain, the part of the brain that I told you controlled, coordination and balance and things like this. So let's say you get called for a patient that's just dizzy. Let's say that they've got all the classic risk factors. They're diabetic, they're hypertensive, they have high cholesterol, and they're just dizzy. They can't stop vomiting. No history of anything like vertigo, which can cause that room spinning dizziness and things like that. There is actually a syndrome that's listed right up here, the vertebrobasilar stroke. That is a stroke, blood clot basically, within these posterior vessels back here that go to the cerebellum part of the brain. And that's a scary thing, because dizziness, even me as an ER doctor, the first thing that I'm not thinking about is stroke. I've got probably 5 other things that I'm considering before I get to stroke. It is always something I think about, because there's been recently a ton of lawsuits for missing these specific stroke symptoms, so it's been emphasized in a lot of education, but it's still not the #1 thing that any of us are thinking about if we have a dizzy, vomiting patient. The scary thing about these posterior strokes is what I'm going to call this instead of vertebrobasilar strokes. Posterior strokes, because it's the back of the head, is that if we plug this into our calculator, let's say we plug it into the Cincinnati stroke scale first. That's not going to get us any points, right? That's going to be a 0. That's going to suggest, just based on the assessment tools we used out in the field, that this person's not having a stroke, right? Same thing, honestly, with that NIH stroke scale that we talked about earlier as well. If I plugged this person in, they're able to move their arms, their legs, they're able to feel everything, see everything. They're not having trouble forming words and things like that. The scary trap is that these people, when plugged into those stroke calculators for stroke severity and things like that, they come up with a 0. So it's easy to miss these things and easy to get a little bit distracted, but we're all smart in terms of our abilities to figure these things out. And I ask that this be something that is at least in the back of your mind now that we've talked about it once. If you have that older patient with risk factors with uncontrollable dizziness and vomiting, could this be a stroke? Should we ask the questions about trauma and medication and the last time they weren't, dizzy and throwing up their guts and things like that? Because ultimately, if we have that information, getting this patient the right treatment, which is sometimes, sucking out clots or putting a stent in the circulation back here, that's an important thing, to try to get them some regained function. And if you guys are slick as the first responders, that just greases the wheel in the right direction moving forward. So I wanted to say thank you to you guys that have made it this far. I know having a non-interactive presentation is not the best way to do things necessarily, but we're limited by the current COVID environment and everything like that. Just had a few closing thoughts, or really just one. We've hammered on everything that is expected of us at the first responder level out there, what we need to be able to do, and the information we need to be able to garner and pass along up the chain to transport and eventually to one of the ER providers working in the ER. It's easy not to be thinking about stroke when it's not right in your face in terms of arm or leg weakness and things like that, but just always have these little nuggets in the back of your mind, and we'll be able to do the best for the patients in terms of early recognition, and if it's available and appropriate, early treatment. So I wanted to say thanks again. I'm always a little nervous making presentations like this, and this is the first time using this setup with the webcam and everything like that, but I wanted you guys to be able to see me and not just have a terrible narrated PowerPoint. This makes it, probably like 0.1% more tolerable to have my face in there, at least I hope. But thank you if you've made it this far. I look forward truly to being able to work with you in the months and years to come when it becomes more appropriate to be out and about and meet everybody and things like that. On the next slide, I'm going to leave it with my email address for contact information. I probably won't leave my phone number, although it's not a secret. You can get it from people just because this is going to be posted to YouTube, and I don't want that completely public. But go ahead and give me an email anytime with any needs or questions or anything like that. And I look forward, like I said, to getting in touch and being able to interact with you guys and be a part of your service in the months and years to come. Thank you very much.